Good morning. My name is Craig Hofmeister. I am living in Atlanta, which has exactly the same temperature it is here, and which I didn't expect. Oh, would you like? Okay, fine. So I'm here to talk a little bit about some of the basics about myeloma and how to think about side effects that many patients have when they're in the midst of initial treatment. You get a little bit of this organization about how things start from Dr. Sporov, and I'm just going to continue on that same idea, is that MGUS and smoldering myeloma, two of the world's dumbest names, basically say that you have a rogue group of immune cells that aren't currently attacking you and don't seem like they're about to, and hence you don't bother them. And smoldering is not myeloma on simmer. It's not a cooking analogy. I hear this all the time, and that's not what this is. Basically, at some point in every patient, MGUS and smoldering myeloma will eventually lead to multiple myeloma, but you might have to live 200 years to get there. So it's a predilection towards degeneration, which is myeloma, but it doesn't happen in the majority of patients with MGUS and in many patients with smoldering myeloma. So many patients sit right over here and never progress to myeloma. And when these cells start trying to kill you, that's why we call them myeloma. And basically, they either chew at your bones, they fill up your bone marrow, or they make proteins which clog your kidneys and lead to kidney failure. The majority of myeloma patients present tired, anemic, with a fracture, and with some evidence of kidney failure. The wheels have fallen off the wagon, and they feel horrible. Now, we made this more complicated with more acronyms. But we did it for a good reason. We wanted to avoid patients from suffering. So we wanted to try to find patients who currently didn't look like their mutated plasma cells were affecting them, but looked like they were high risk to have that occur. And so we added in some additional characteristics. We said, hey, if you have 60% of these cells in your bone marrow, but they're still not attacking you, maybe we should just treat this as myeloma. If you have abnormalities on MRI in multiple locations, maybe we should just treat this as myeloma. Or the worst one is if your serum free light chain ratio is greater than 100, then maybe we should just treat you as if you have myeloma. These are not perfect. These are predictions. These are trying to prevent patients with smoldering myeloma from showing up in the clinic with 2 compression fractures and saying to the doctor, hey doc, I don't think I have smoldering myeloma anymore. These compression fractures suggest I have myeloma. Do you think you want to treat this? That's not what we want. We never want anyone to have a compression fracture because you can never take that back. And so trying to change this to make it slightly more complicated, to treat these patients before they have clear evidence that their myeloma cells are attacking them, that's the purpose of making this more complicated. And majority of patients basically show on the left-hand side, they present with back pain. If you look closely here, this is this spot here. This is the cartoon. This is the MRI, a squished vertebra. This is what causes pain. And if you stick a needle right in here and lay that out on a slide, this is wall-to-wall myeloma. And myeloma cells in a cartoon make these monoclonal proteins, which get filtered by the kidney and scar the kidney as they go through the kidney. These myeloma cells can also fill up the bone marrow and chew at the outer structural portion of the bones. That's where we all store our calcium. As they chew through the calcium, they weaken the bones, and gravity is always pushing down. It puts us at risk of developing fracture. And then filling up the marrow can increase your risk of infections and worsen anemia. This is a busy slide. I'm not going to go crazy on this, but basically we have very clear criteria for what makes you into patients with multiple myeloma and the sister disorder, AL amyloidosis. AL amyloidosis is essentially patients with MGUS that have a protein that just happens to get deposited in organs in a patient and lead to oftentimes kidney failure, heart failure. These patients are usually not attacked in their bones. They don't have horrible anemia. They don't have their bone marrow filled up with these plasma cells, but the protein itself, the circulating protein, is what's killing these patients with heart failure and kidney failure. So I always think of myeloma cells as termites, because no one likes termites. Actually, no one likes cockroaches. That's more of an Atlanta thing. Oh, what a pain. But anyway, back to work. So termites this is the myeloma cells, and they're chewing at the foundation of your house, which is your skeleton. And that leads to holes in your bones and puts you at risk for fracture. Chemotherapy is like these little termite killers. And the reason we are here now and we're not where we want to be is because most of these killers kill the worker bees and they don't kill the queen bee. And that's what we need to do. We need to push towards new and novel treatments that can get rid of all the myeloma cells, not just the worker bees, because we're pretty good at killing the worker bees. Stage. We misuse the word stage in myeloma. So breast cancer, colon cancer, lung cancer, prostate cancer, all of them use the word stage to mean where is your cancer. And we use the word stage totally differently. And we are always upset that patients don't understand why what we mean with stage. So stage 1 myeloma means you are expected to have easier to treat myeloma. In myeloma, where myeloma cells are spread throughout the body at diagnosis, the location is not linked to survival. Location is not what happens, is not relevant in myeloma, but it's very relevant in breast cancer, colon cancer, lung cancer, prostate cancer. Metastatic breast cancer is much worse than breast cancer is just in the right upper outer quadrant that you can cut out and cure. So in myeloma, it's spread out for stage 1, stage 2, stage 3. Where the cancer is in myeloma is not relevant for survival. So staging for us is solely linked to what kind of myeloma do you have. Do you have more difficult to treat myeloma or easier to treat myeloma? And so the vast majority of patients, 60% of them, are right in the middle. We're not quite sure whether they have easier to treat disease, stage 1, or harder to treat disease, stage 3. So stage 1, staging in myeloma is complicated, but stage here is synonymous with risk. High risk myeloma, which is more difficult to treat, which is has a more predilection to become resistant to treatment. It doesn't make it easier. We have 4 staging systems that I document in every note, so that adds to the confusion for patients. But staging is all trying to get at the idea of what kind of myeloma do you have. There are lots of treatments, and if you think of paradigm shifts, this slide is where I want to sit for a second. So it started out a little bit with steroids. Actually, it started out with Coca-Cola in a clinical trial that I'm not going to talk about. But that said, steroids are the drugs we love to hate. They make every myeloma treatment work twice as well, to the detriment of the patient. Proteasome inhibitors, you guys are familiar with Velcade, Kyprolis, Ninlaro. They attack the myeloma cells. IMiDs or cell mods, you've heard of Revlimid and Pomalyst, and you will hear about iberdomide and others. These attack the inner workings of the myeloma cell, and all of these drugs affect what goes on inside the cell. Now, newer things, CD38 antibodies like Darzalex and Sarclisa, CAR T cells and bispecific antibodies, these look at what's on the outside of the myeloma cell. It doesn't matter what's going on inside. What matters is what proteins, what vulnerabilities are present on the outside of the cell. And CAR T cells work because they look for a particular protein on the cell surface, and they look to try to find myeloma cells that are vulnerable, that haven't surrounded themselves with an army. So I have to tell this one joke. I always tell this joke. I love this joke. The idea is that when you do a bone marrow biopsy and you pull myeloma cells out of a patient and you put them on a dish, they just die. They die in 90% of the time. And this is just like my in-laws. My in-laws have created a situation that promotes their survival. And if you pull them out and drop them over here, they're just going to do terribly. This is not going to work out well. My in-laws have created this bone marrow to support their growth and to continue their long life. Myeloma cells are just like that. And CAR T cells, everyone wonders, wait a minute, if myeloma cells all express this protein, why don't CAR T cells work for everyone? And what happens is that they're so good at creating that system around them to support their growth, the CAR T cells don't even have a chance to be successful. So CAR T cells work for the majority of patients, but some myeloma cells are so good at creating a protective cocoon around themselves, sometimes they're not always effective. So while this new paradigm of drugs is very effective, it's not 100%. Okay. On average, for most of my myeloma patients who present fatigued, anemic, with fractures and kidney failure, in the ER, wondering what happened, most of us are trying to treat them until things are as good as they're going to get, until the myeloma patient is doing as well as they can. And this usually takes 2 to 4 months and usually involves a variety of treatments and a variety of drug cocktails that are very complicated. These are the same drugs we just talked about, but they're pills, they're shots, and they each have different potential complications and side effects that we're going to go over in a subsequent slide. Autologous transplant is sometimes used for patients, and this usually is essentially just high-dose intravenous melphalan, which is a chemotherapy drug, and we're transplanting your own stem cells right back to you, but those cells don't get exposed to melphalan, and hence they are able to quickly reconstitute your bone marrow so that you have a very short time where you don't have much of an immune system. And finally, most patients are usually on single drug Revlimid maintenance, and this adds another period of time, usually 20 months for the Revlimid maintenance and about 30 months for transplant is how long. And when I think of how good treatments are, I think of their value. How long do they keep the myeloma quiet if they're not going to cure? And how much pain and suffering do you have to go through for that amount of disease control? And when you think about disease control, all right, so this is my most complicated slide. It has the most amount of jargon. Just kind of breathe through it here. It's going to be okay. So the idea is how long will your myeloma be in control? And I took a whole bunch of national trials and how long did they keep the myeloma quiet? So this is Revlimid and dexamethasone. If you keep doing that forever until the myeloma is resistant, that buys you 24 months of disease control on average. If you do Revlimid and dexamethasone and an autologous transplant and then you stop, that's 34 months. RVD and then RD, that's 41 months. RVD, autologous transplant, and Revlimid for just 13 months, 47 months. DARA, Revlimid, and dexamethasone until resistance, that gets you 66 months. And then we'll just go to the bottom here. DARA, RVD, Darzalex, Revlimid, Velcade, dexamethasone, autologous transplant, and DARA and Revlimid together for 2 years, followed by Revlimid, will likely be around 90 months on average. So things are getting better. The drug cocktails are better able to control the myeloma, but it is more complicated and it is more drugs. All right, this is my second most complicated slide. So treatment for the newly diagnosed. And I think that we should personalize treatment. And that's the other paradigm shift, is that not everyone should get the same treatment, because we want to bring forth the best value, the best disease control with the least amount of side effects. So for patients who have high-risk disease, these are patients in general who have stage 3 disease or other markers that suggest they're going to be very treatment resistant. These patients are very challenging. They will get 3 or 4 drug initial treatment, autologous transplant, and ongoing treatment thereafter. This autologous transplant I classify as low value. It doesn't provide very much disease control, but has the same amount of side effects, no matter what kind of myeloma you have. In patients with low risk or easier to treat disease, they'll often get 4 drug induction, transplant, and then if they're in a deep remission, we're going to stop treatment. And there the transplant is high value. Same amount of side effects, but their disease is more likely to respond, more likely to stay quiet. None of this is curable. So we're looking to try to find the least amount of side effects for the best amount of disease control. I'm going to keep going in the interest of time here. All right, everyone insults myeloma physicians for having ABCDs of myeloma treatment. We love to put an acronym on everything, and you think it's to exclude you, and honestly, it's just hard to say all these chemotherapy combinations. DARA-RVD is these 4 drugs. DARA-KRD is these 4 drugs. It gets confusing, and some of these acronyms I put on this slide just to give you some comfort with it. All right, this is Catherine Maples. She is a clinical pharmacy specialist that I work with, and she worked in collaboration on the following couple slides on side effects. Revlimid. Revlimid is one of those drugs that if you get a rash to Revlimid, that does not mean you're allergic to Revlimid. It is one of the few drugs where you can say that and kind of roll your eyes like my 17-year-old rolls her eyes when I talk to her. It's a 17-year-old eye roll. This is not an allergy. This is how the drug works. It stimulates some of the immune system. So most of the time, these rashes can be taken care of by taking a non-sedating antihistamine like Claritin, reducing the dose, and then eventually decreasing the dose if need to, if it becomes pesky in the long term. Rash, if you ignore it, can be horrendous. So please communicate with your clinic staff so that they know you're having a rash and can guide you appropriately. This is not the time to be stoic. Diarrhea, also not the time to be stoic. In general, responds some to Imodium, but oftentimes you need something to help the gut work and reabsorb bile acids. So we use a lot of Velcade and Colestid to try to allow patients to take Revlimid without irritating diarrhea. This is very much 1 to 6 tabs per day. This is very much a user-defined amount of drug. It's however much you need to get 1 to 2 soft bowel movements a day. That's what we're looking for. Sedation happens that most patients get tired for taking Revlimid, so we suggest to take it at night. Chemobrain is poorly understood, poorly assessed, and sometimes responds to reducing the dose. Nocturnal cramping or cramping in general. Generally, if you're not taking Revlimid, hydration isn't going to help. But if you are taking Revlimid, hydration can make a difference. And blood clots, obviously, patients need proper anticoagulation. IMiDs and kidney failure. Some doctors will say, oh, you have kidney failure, I can't use Revlimid. That's not true. You just need to dose reduce the Revlimid appropriately because Revlimid's cleared by the kidney. There's almost no patient we can't give Revlimid to if they have moderate kidney disease, severe kidney disease, or they're on dialysis, you can dose reduce the Revlimid and make it tolerable. Proteasome inhibitors, things like Velcade and Kyprolis, these drugs increase your risk for shingles. Shingles is a terrible rash I'd never want you to have. But you can take care of shingles and have almost 100% prevention success by taking Valtrex or acyclovir. Again, these drugs give you either diarrhea or constipation, whichever you don't want. That's what they tend to give you. It's so annoying. So some basic stuff will usually get you through it. The big thing for Velcade is it causes tingling and numbness in your hands and feet. It's cumulative. It's not the time to be quiet. If you have tingling, if you feel cold in your extremities and it's changing with treatment, please tell us, let us know. We want to prevent this tingling and numbness and pain from getting worse. I have literally had patients say, you're busy, I didn't want to tell you. This is when they were being wheeled into the clinic because they couldn't walk anymore. So please tell me if this is going on, if I'm not seeing you, because I want to make sure this does not get out of control. And the best way to treat peripheral neuropathy is to prevent it. Velcade, through its effects on the autonomic nerves, can decrease blood pressure. Carfilzomib or Kyprolis increases your risk of hypertension, high blood pressure, increases your risk for heart failure. Oftentimes for patients who are newly diagnosed, they're often given the question of, hey, do you want a 30% risk that you'll have peripheral neuropathy or a 3% risk of heart failure? 30% risk of neuropathy is with Velcade, a 3% risk of heart failure with Kyprolis. And we don't know which you're going to get. And a lot of times in myeloma, there's a lot of choices that you don't want to make where we have imperfect data. Drug interactions, I saw this and I just get annoyed. It's go ahead, have some vitamin C, drink some green tea, whatever you've seen on the blogosphere is crap. So you can go ahead and have some green tea and vitamin C. It's not going to affect either one of these medications. Lastly, just a couple asides. CD38 antibodies do depress your immune system. They increase your risk of infection. They increase your risk of fatigue. So you need to definitely never forget about shingles prevention in patients with these antibodies. CAR-Ts can affect your normal plasma cells. So trying to give monthly intravenous immune globulins to decrease your risk of infection often can go on for months and even up to a year after CAR-T just to try to decrease risk of infection. Blenrep is a antibody drug conjugate, and sometimes it's better to start a low dose because this drug can be very effective, but it can cause corneal toxicities or corneal side effects on your eyes, causing blurry vision. And while you get an eye visit prior to each and every dose, starting at a slightly lower dose can in many ways prevent eye damage. And then Expovio or selinexor is a very challenging drug to take. Don't forget to take your anti-nausea drugs, at least for the first week, because if you're one of those few patients that can tolerate this with almost no side effects, that's great. But the rest of us are going to have side effects, one of them being nausea, and taking these preventive or prophylactic anti-nausea medications makes some good sense. All right, this is a cartoon slide. I love cartoons. I don't know how I would have gotten through med school without cartoons. But this is a CAR-T, and more folks are going to talk about CAR-Ts here, but I just put in the cartoon because it's nice. Basically, a myeloma patient, you will take T cells out of the myeloma patient through their blood. These T cells are forced to become myeloma warriors. They weren't warriors when they came out in the blood, but they're forced to express markers on their cell surface so that they have to attack myeloma cells whether they want to or not. These cells are infused back into a patient, and what happens is that these CAR T cells connect up to the myeloma cell and lead to the myeloma cell death. So that's how really a CAR T cell works. All right, this is my dog. This is Captain America. He eats anything. But anyway, thank you so much for your time.